Welcome everybody. How are you doing? My name is James Egan. I'm faculty in BCHS. Couple housekeeping stuff to go over first. Today we're going to be recording this as we record all of these conversations, and I recommend going and checking out the website at Pitt Public Health to look at the ones that have happened before and maybe the ones that are coming up. We're going to use the Q&A feature today, so use that to type in your questions, and then I'm going to help moderate the questions to our panelists. And then next week is, I think, going to be Drs. Friedman and Creer, and they're going to talk about HIV-related stigma in healthcare settings during COVID-19. But today, we're going to talk about harm reduction approach, implications for the COVID-19 pandemic. That's going to be really exciting. It's going to be fun. We have two people here talking, two spectacular scientists. Dr. Julia Marcus, who is an infectious disease epidemiologist and associate professor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute. And her research focuses primarily on pre-exposure prophylaxis, or PrEP, for HIV, both in terms of looking at big data sets and also implementation studies. The other person we have is our very own Dr. Mary Hawk, who's an associate professor at BCHS in Pitt Public Health. And she does a lot of work with structural stigma interventions, or implementation of structural interventions to reduce the impact of HIV and AIDS, and is also a superstar evaluator. So I'm going to turn this over because you didn't buy tickets to hear me talk, you bought tickets to hear them talk. So I'm going to turn to Julia first. Dr. Marcus first, please.
Hi, thanks so much for that invitation. Very glad to be here. I'm going to share my slides with you all. As Jamie said, I'm an HIV prevention researcher, and I've been really thinking about the COVID pandemic through that lens and watching some of the same patterns play out during COVID on kind of an accelerated timeline as what we've seen in HIV. And I think there are some important lessons that we can draw, even though these are two very different viruses, very different responses. I think there's still some important lessons we can bring from HIV and from harm reduction in general to our current situation. So I started thinking about this in April in particular, when people started venturing out of their houses, and I saw a lot of shaming going on for people being in parks and people enjoying themselves outdoors. And it just made me think a lot about the shaming that we've seen in HIV and the ways that that has perpetuated stigma and has led to some of us here today whose careers are built around trying to reduce that stigma to have a better impact on the HIV epidemic. And so what I started writing about was the ways that we know abstinence-only messaging doesn't work for sex or for substance use, and how it's not going to work for social contact either, because we really have to recognize that people are human. They need some social connection, and we have to make sure that we're designing our public health messaging and our policies in a way that recognizes that as a core need and is a more realistic and pragmatic approach. So first, I want to define harm reduction in its truest sense, which is as a framework and movement that's developed by and for people who use drugs. Refers to policies, programs, and practices that aim to minimize negative health, social, and legal impacts associated with drug use, drug policies, and drug laws. Grounded in justice and human rights, and it focuses on positive change and on working with people without judgment, coercion, discrimination, or requiring that they stop using drugs as a precondition of support. So I'm kind of borrowing from this framework some tenets that I think can be useful for other areas of public health, not just sexual transmission of HIV and STIs, but also where we are now with COVID. So first I want to define an abstinence-only framework versus harm reduction, and then which I see as pretty much oppositional. And then I'll give some examples of how this is playing out right now. So first, the way that we think about risk in an abstinence-only framework tends to be very binary. You're either safe or you're unsafe. In the context of COVID, you're either in your house safe or you're out of your house and you're unsafe. Of course, that's an oversimplification, but we have seen a lot of binary messaging during this pandemic that I think reflects this abstinence-only framework. In contrast, harm reduction considers risk to be more of a spectrum, which in fact it is. There's a lot in between no risk and a probability of 1. There's a whole range there, and recognizing that spectrum offers a lot more opportunities for bringing people to a lower risk end of the spectrum from that high risk end. In the abstinence-only framework, drivers of risk are generally seen to be individual level, really coming down to personal choice. Like you chose to take this risk. And in the harm reduction framework, we're really thinking about the context in which people make decisions. So yes, there is some element of personal choice usually, but that's also constrained by people's context, including structural inequities, including structural racism, and ways that those shape the decisions that people can make and the risk that is conferred when they make those decisions. In the abstinence-only framework, high-risk behavior, because it's seen as a personal choice, tends to be framed as a personal failure. And here, if you take anything from this talk, take this. In the harm reduction framework, high-risk behavior is framed as an unmet need. And that fundamentally changes everything about how we message and how we design policies. Instead of thinking of risky behavior as somebody being selfish or reckless or just failing, we think about what is it that they actually needed here and how can we help them find a safer way to meet that need. Correspondingly, because we're thinking about personal failure, the messaging in an abstinence-only framework tends to be very moralistic. And that may include shame-based messaging that perpetuates stigma and ends up driving people away from public health efforts. In the harm reduction framework, because we're thinking about that unmet need, messaging tends to be much more compassionate and even empathetic. In the abstinence-only framework, when people engage in risky behavior, the response tends to be punitive because we're thinking, well, they failed and they're a bad person. And then in the harm reduction framework, we're thinking about that unmet need. We're thinking in a much more compassionate way, and our response tends to be supportive. We try to give people resources so that they can reduce their risk. And then finally, in the abstinence-only framework, the conception of health tends to be myopic. So in the case of, let's say, COVID, we're thinking very much about preventing infection. And sometimes that comes at the expense of other aspects of health. But when we start to think about a broader context of health and a broader context of the way, in the harm reduction framework, thinking about the contextual factors that drive risk, we're just thinking much more broadly, and we start to think about health in a much more holistic way. And recognize that sometimes the reasons people engage in one kind of risk behavior is that they're trying to meet some other health need. And once we see that, we can start to come up with much better solutions. So I want to give some examples just from what we're all living through right now, starting with this idea of risk being either a binary or a spectrum. I think the binary messaging really started in March with good reason at the time. Telling people to just stay home. And there was not any kind of spectrum of risk provided at that point. It was really just stay home, save lives. And that has evolved over time appropriately. But I think we still see a lot of binary messaging, almost one intervention at a time, masks, testing, just one thing after another. I think we tend to think in these dichotomies. And I think what's helpful is thinking about this more as a spectrum so that people can really conceptualize, okay, that's the highest risk thing that I need to avoid. But if I do engage in that high risk activity, what are ways that I can reduce my risk? If I do have that indoor party, what can I do? And maybe actually, once you start to see this spectrum, you can think, oh, I really need to interact with people. And now I can see ways that I can do that are safer, that are not zero risk, let's say outdoor gatherings. But much safer than indoor gatherings. So this idea of drivers of risk being individual versus contextual, there's been a lot of emphasis on individual drivers of risk in this pandemic, particularly this focus on personal responsibility. I see that phrase often as a red flag, as a way of erasing the context that surrounds people. And in this case, I think when we have federal public health officials saying, if you could just social distance, wear a face mask, avoid crowds, and wash your hands, we could end this pandemic. I think that kind of erases the responsibility of of those institutions to support people in reducing their risk. And when we really look at what's happening in the context, this is one of many, many examples. This is a study that looked at subway use in New York City as correlated with income in March. And the red line is people with the lowest income, the blue line, the people with the highest income. And of course, subway use, it declined much more for people with higher incomes. And this correlates then with morbidity and mortality. So we're seeing these very strong socioeconomic and racial and ethnic disparities in COVID morbidity and mortality that reflect the real drivers of the pandemic, including crowded households and occupational risks. And when we talk only about personal responsibility, which yes, it's key, personal responsibility is key, but when we focus on that at the exclusion of these contextual factors, then we lose sight of what is really driving risk. So some examples of moralistic messaging. I'm going to give you a few examples from Twitter, and these are de-identified tweets from health professionals with very large platforms, tens or even hundreds of thousands of followers. And these are specifically around masks. And this kind of messaging, I think, has been very common. And I'll also say this messaging is really understandable, but may not have the effect that we want it to have. I think mask wearing at this press conference is a reasonable litmus test for whether or not you're a callous moron. Just ran 4 miles in a KN95 mask and I'm not hypoxic. You know why? Because I'm a goddamn American and real Americans don't whine like a bunch of little snowflakes. Can you imagine being so insecure that wearing a mask for a little while is a threat to your masculinity? So we don't expect to hear messaging like this when we go to the doctor and ask for birth control or statins. We don't expect them to say, you know what, you're a callous moron for engaging in this risky behavior. And somehow it's I think, become more acceptable during this pandemic to do that. And I think there are certain things that are more stigmatized than others. And in this case, I think it's very hard, first of all, as a health professional who may be seeing patients, COVID patients, I think it's really hard to disentangle the frustration that you feel about people engaging in risk from your public health messaging. But I think also it's for some people, for some health professionals, really hard to understand why somebody wouldn't just wear a mask. And that frustration comes out in this messaging, which I think can polarize people and actually drive them away from public health. So I want to give some examples of alternative messages around masks. And these came out of California. There were a couple of video campaigns to try to promote mask use. Here's one with former Governor Jerry Brown saying, look, nobody wants to wear these things. And this is a small act, right? Just acknowledging that no one wants to do this. But it's huge. It makes such a difference when we start from a place of empathy and say, you know what, I get it. I don't want to wear one of these either. And that actually can build trust. And so then people become much more willing to hear what else he has to say. And in another campaign, they acknowledged the ways that masks impede social connection with hidden smiles and muffled laughs. And they talked about fogged glasses, all these inconveniences that, while minor, actually do contribute to people not wanting to wear a mask or even just having a hard time wearing one. And again, that kind of compassionate messaging builds trust. And instead of dismissing this concern about, masks being a sign of weakness or a threat to masculinity, they addressed it head on. They had Arnold Schwarzenegger, who we all will forever think of as the Terminator, saying this is not about being weak. So high-risk behavior as a personal failure versus an unmet need. I'm going to give some examples from what I think has been one of the most prominent ways that individuals have been blamed for driving the pandemic, and that's young adults and college students in particular and partying. California's COVID-19 crisis being fueled by raucous parties, young adults, and this was a message from Syracuse leadership to students who'd been gathering outdoors actually. Last night's selfish and reckless behavior, and I think this email used the word selfish another 4 or 5 times after that. The university had a great coronavirus plan, but students partied on. So yes, we need to help people avoid indoor parties. That is where we're most likely to see super spreader events, and we want to focus our efforts on where risk is highest, and that is a situation where risk is high. But the way to do that is not to condemn people, to blame them, and and tell them that they're being selfish and reckless. It's to step back and say, what is the unmet need here? Well, the unmet need is for social connection and for fun. Yeah, for fun. We need to enjoy our lives, and there's nothing wrong with that in a pandemic. What we want to do is help people stay socially connected and enjoy their lives in a way that's safer. So, for example, Notre Dame actually set up an outdoor area where students can gather more safely. They made it really appealing. They have Adirondack chairs, fire pits, umbrellas, lights, and this is a way of saying, we understand that you need social contact. Here's a way to do this more safely, rather than taking that abstinence-only approach. And here's an example, not on a college campus, but this was in Toronto, where a parking lot, they changed regulations around the use of a parking lot to open a beer garden. And this is in a neighborhood where very few people have private outdoor space. And so it really serves a need, which is that people need a space to gather that's safer than their apartments. I have been really kind of disturbed by how quickly we've gone toward punitive responses in this pandemic. And we've seen that in HIV and in substance use, really notably in substance use. But we're seeing it now playing out in real time with COVID. And we all know what happens when we bring in the police. Here's a video of an NYPD officer punching a man after an alleged social distancing violation. And it's no surprise that this man is Black. Most of the people who have been arrested in New York, which tracks this data for social distancing violations, have been Black, almost exclusively. And this is also not a way to deter behavior, because it isn't addressing the unmet need. So that's what I want to keep coming back to. A more supportive response, and although this is not about social distancing necessarily, but about isolation and quarantine, is to really think about that context. Do we need to be worrying about people who are not social distancing outdoors? Probably not that much. It's not as much a concern. But yes, we need to worry about whether people can safely isolate if they live in a multi-generational household, because that is really a huge driving factor of the pandemic, not just in the US, but worldwide. And so this is an example from King County in Washington where they're providing safe isolation spaces for essential workers who have a high-risk person at home, multi-generational households, travelers, people without permanent housing, etc. And then finally, an example of thinking about health in a myopic way versus a holistic way. When we think about health as just, in this case, just COVID prevention, we forget about people's need for social connection and even for just frivolity, right? Just enjoying their lives. And it inspires moral outrage when we see people having a great time in a pandemic, even if it's fairly low risk. This is Mayor Lori Lightfoot in Chicago saying, it's called a pandemic, people. This reckless behavior on the beach is what's going to cause us to shut down the parks and lakefront. Don't make us take steps backwards. And in fact, after this picture was taken and posted, they did send in the cops who barricaded the beach while the restaurant next to the beach remained open. So there's a bit of a disconnect here where there's kind of an unscientific moralism that ends up happening and a focus on infection prevention at the expense of other aspects of health. And then I'll give this kind of controversial example that I think is really poignant from the New York City Health Department, which put out safer sex guidelines during the pandemic really early on in March, actually, and then updated them several months later. And in those guidelines they said, look, we know people are going to have sex in a pandemic. So instead of taking the approach of saying, just don't have sex with anybody outside of your household, which is likely to be unrealistic, they said, we know some of you are going to have sex. We're going to give you tips on safer ways to do it. And yes, they threw in glory holes and the media had a field day, but the whole point was they were acknowledging people's basic human needs and behavior. So some key points to take home with you: an abstinence-only approach to COVID-19 has unintended consequences. And those include shaming, blaming, and punishment, which can be toxic to public health. And instead, a harm reduction framework can guide a much more compassionate, pragmatic, and humane response that I think will help us preserve our collective humanity in this crisis. Thank you so much. I'm going to end with these words from Dr. Bonnie Henry, who's the provincial health officer in British Columbia, who has been saying throughout the pandemic, be calm, be kind, be safe.
Thank you very much, Dr. Marcus. We're all, snaps, claps, all that kind of stuff. It's strange not to be able to see people doing it, but I'll clap for you.
Me too.
Just a reminder to folks, that was fantastic, Dr. Marcus. Thank you so much. Very interesting. I look forward to discussing this along with Dr. Hawk's talk all at the end. But I just wanted to remind folks that the Q&A feature is open and you can post questions now that we can talk about after Dr. Hawk. Over to you.
Thank you. Let me get my screen up. All right. How's that look? I think that's actually not working. Hold on one second.
We can see it, Mary, we could see it.
All right. For some reason, the green highlight was not showing up for me. All right. Still good?
I can see it.
Awesome. Thank you. So I'm going to be walking us through some main concepts from a paper that we wrote actually after being inspired by a piece Julia wrote in The Atlantic. So this summer, Jesse Burke invited a group of us to think about planning for higher education during the pandemic, as informed by a set of harm reduction principles that we had previously developed through an evaluation study we conducted with our friends at the Positive Health Clinic here in Pittsburgh. So the harm reduction principles are premised on the idea that although harm reduction is rooted in substance use and developed by people who use substances, it can be applied to most, if not all, health issues. And this sparked a lot of discussion within our group because, of course, you know, harm reduction evolved from people who use drugs. And we want to make sure that we're honoring that work, the work of people with lived experiences, and not exploiting or co-opting that work. But, you know, I think anytime we think about health behaviors and health outcomes moralistically, or as a binary, both as Julia was talking about, we risk losing the person that we say that we want to be helping. So we really want to promote the harm reduction principles as a standard of care, not only because it will be better for all of us, but also because, and especially because, if we can normalize the harm reduction principles as a generalized approach or standard of care, it'll be even more useful for oppressed populations who are often excluded from well-serving health interventions, or health interventions that serve them well, I should say. So as we move through this content, I'll be referring both to the principles paper, which is the original harm reduction principles paper that we wrote a few years ago, as well as the COVID paper, which you see here. I'm pointing to my screen as if you can see it, but you can see it on your screen. And that COVID paper is this compassion and framework paper where we apply the harm reduction principles to our thinking about the pandemic in higher education. Okay, so the first of our harm reduction principles that we applied to the COVID thinking is humanism, which is really the foundation of all the principles, and certainly closely tied with compassion. So humanism captures the idea that people make health choices for a reason, and even harmful health behaviors provide some benefit, whether we're talking about substance use or COVID risk mitigation. And so those benefits that drive people's decisions must be assessed and acknowledged in order to understand the balance between harms and benefits. And it's really important that we don't take away people's dignity by disrespecting them, even if we have empirical evidence that choices they're making are suboptimal or even harmful. And the way we applied this principle in the COVID paper is by encouraging leaders in higher education to create safe and respectful spaces to explore what drives people's decisions around COVID risk mitigation. And this is hard, right? Understanding others' decisions is really hard, especially when we feel like those decisions that they're making may endanger us. But it's super important because as much as we might want to say things like just say no or just do it, we know these don't work in public health messaging, and they never have. Harm reduction has always been about sort of stopping the groupthink of fear and striving for compassion and not otherizing people. Our second principle is pragmatism, which reflects the idea that behaviors and the ability to change them are influenced by social and community norms, and that none of us have perfect health behaviors. I'm sad to tell you. I know I don't. So our behaviors don't occur in a vacuum. None of us, again, have perfect health behaviors. And these behaviors are rarely clear-cut decisions, but are actually influenced by many factors, both proximal and distal, and informed by both short and long-term thinking. And so considering health behaviors in the pandemic, when we're thinking about them, it's really important to understand people's competing demands. And I would love it if questions like what do people need in the pandemic became a greater part of the zeitgeist, if you will, when we're exploring health and public health messaging in the pandemic. Because too often we're thinking and restricting these discussions to ideas about what people should do and not what do they need in order to be healthier. Our next principle is individualism, which captures the idea that we all have our own needs and strengths, and therefore our supports and health interventions must be tailored to those needs and strengths. And obviously, when we're talking about public health policy, we do strive for some sort of umbrella approach, but these should be informed by diverse strengths and needs and not by those of a single person or a single group. And one example of what this means for our campus during the pandemic is that, students coming from high impact areas or those who have fragile family members need a variety of supportive options. And so we can't think about the student body as one homogeneous group that can follow the same set of guidelines in all situations. And it's also, therefore, really important that we think about the fact that health and social inequities directly impact individuals' needs. And so, for example, people who work in the food industry or who rely on public transportation have limited choices and higher risk for infection, which is, Julie, I was so glad to see that slide with the subway curve that clearly demonstrates people's access to transportation is affecting their risk. So acknowledging the ways that marginalized communities are impacted by COVID-19 when making decisions about the pandemic as higher education leaders is really important. Autonomy underscores people's right to make their own health choices. And so the question is, during the pandemic, how can we create environments where people can mitigate COVID risk successfully, but in a way that is meaningful and acceptable to the individual, to them? What do we need to do to create safe spaces where students' decisions and their autonomy can be supportive while still striving to ensure public safety? And, as Julia already pointed out, social and psychological and sexual needs are real, but we're really not talking about these very much. We seem to be mostly talking about the fact that people should just socially distance without thinking about the other needs that they experience. So we need to consider ways that harm reduction at the population level can support harm reduction and autonomous health decision-making at the individual level, which is really trying to find the balance between autonomy and public health in higher education and the settings we're living in. With incrementalism, we're celebrating every step forward and every positive change. And so an example of incrementalism that we can see in the pandemic is the creation of pods on campuses like our own, where we understand that while asking every student to self-isolate forever would be, in theory, empirically speaking, the safest way to approach COVID, we know that that's not realistic, and that asking them to do that would actually be increasing other harms, like harms to their mental health, for example. So rather than asking people to self-isolate, completely alone, we're encouraging the use of pods where students sort of quasi-isolate in small groups, which is a mechanism of harm reduction in itself. And, it's important that we plan for backwards movements, because what feels right for people, what they're able to do today, is not necessarily what they're able to do tomorrow. So we have to keep working at this. It's not it's not that we've found the perfect solution yet, but it's going to be an ongoing evolution. And we're going to have to realize that as we do well, we're going to have to realize that there'll be times when we may slip back, and that's not a failure. It's part of the process. We know that young adults especially often feel invulnerable and make decisions for the right now rather than for the long term. So our challenge then is to help them move towards long-term thinking. And in the pandemic, this is really hard because, we clearly have national leadership that is telling us that some people are not vulnerable and long-term thinking isn't necessary. All the same, we know that thinking about public health in this way in baby steps, in small bites, is really challenging because the extreme nature of the pandemic is a lot to contemplate. So waiting for people to be safe feels like it puts us all at risk. And I want you to hear clearly that I'm not saying by any means it's okay not to wear a mask or it's okay to not socially distance, because those things aren't true and I'm not saying them, and because they would probably take away my public health badge and I'd be out of a job. But what I am saying, like Julia has already noted, is that we need to encourage a community to support a community that helps people inch closer to optimal health behaviors, and that celebrating successes is always much more effective than punishing misses. And finally, the last principle we have has to do with not ending relationships with people when they continue harmful health behaviors. And this is important because we've already discussed the fact that none of us actually have perfect health behaviors. Although I will note that when you are privileged, your imperfect behaviors are certainly better tolerated or perhaps even embraced. So in application of the pandemic, what we want to do is to find ways to mitigate behaviors that create risk for community, mitigate behaviors that create risk for the community without making social pariahs out of people. So making sure that we're helping people increase their risk protective behaviors, but not, as Julia noted, punishing them when they are not able to reach our risk mitigation targets. So we're seeing in real time that an us versus them narrative is occurring, and this is likely driving people deeper into their mental models rather than creating space for open dialogue and fact sharing. And so in the long term, this us versus them mentality, where we punish people for not wearing masks without understanding what's going on with that, is probably going to reinforce the not wearing of masks rather than support the wearing of masks. And, you know, much in alignment with what Julia was saying, if we treat this as a binary process, we're going to keep being in trouble. So I just wanted to throw this slide up for a moment to link to the harm reduction principles paper that I'm using to talk through these slides. If you actually just point the camera on your phone to that QR code, it will open up a link to the harm reduction principles paper, which is open for use. And Jamie is also a co-author on that paper. So I have both of our email addresses there in case you would like more information. And, you know, I think the last thing I would just like to say is that we've already noted that harm reduction importantly builds on the work of peers. And I think it's really important for us to keep talking about the ways that we're making most of our peers, including our students, in the academic community. And, you know, I would just love to know more, have a discussion about ways that we're developing public health messaging and options for engagement based on what our students and other members of our academic community are telling us. Thank you.
Claps for Dr. Hawk. Thank you very much. Snaps and claps. Dr. Marcus, I think I'd like to invite you back. Thank you very much. Thank you, Dr. Hawk. That was fantastic. Very interesting. And you also check out those papers if you want. They're great. Reminder to send in your questions if you have things that you want to talk about to the Q&A feature. But I'm going to start with, there's one question that came up, a couple that are related a little bit to Dr. Hawk's last point, but how should we think about the politicization of the pandemic vis-a-vis the issue of harm reduction? Is there a role for shaming approach in combating the political messages? Or do we think that it's a bad idea regardless? And then another question that came in was about similar, apparently somebody, I didn't hear the news, but top public health official told me I have to stay home and eat my turkey dinner all by myself in my apartment, and that I shouldn't go anywhere because he's gonna, or she or he is gonna stay home and not travel, and so feeling like I have to stay home too. So those are, what do we think of that?
Yeah, that was a lot. So, you know, for me, in terms of the issue of the shaming approach, I think that's never going to be useful. And I think in our current political environment in particular, we're forcing people to either end of the continuum, right? You wear a mask, you don't wear a mask. You're a, you know, and so I think that shaming is never successful. And, you know, Julia, I think you had some great slides that address that. I'm sure you have some thoughts about that as well.
Yeah, I think it's a great question. And often when I talk about shaming in health, people will say, well, we're shaming for this other thing. And I think, and I just got this question the other day specifically about Notre Dame, because of course the president of Notre Dame had been infected at the, you know, White House super spreader event, and he had been not role modeling his own guidelines that they had been trying to get students to adhere to in Notre Dame. And so the students had reported the president on their snitch line and said he should resign. And so I was asked, well, what is the role for shaming the other way around? Like, can the students shame the president here? And I think there needs to be a distinction made between shaming people for their individual health behaviors versus holding leaders accountable for not doing their jobs effectively. I think that latter part we have to do. Like, that's essential, and especially right now, we need to be holding leaders accountable. And I don't think that necessarily means we have to say they are terrible people, but I think we need to hold them accountable for their behaviors that are not consistent with, you know, what they should be doing in their role.
Go ahead, Dr. Hawk. It looks like you have something to say.
Yeah, I'm just trying to frame my thoughts. I think that, you know, when I'm hearing language like shaming, it's increasing stigma. And I've been thinking a lot about a comment that one of our colleagues made this week. Dr. Creer is actually presenting next week in the COVID conversation, where she made the comment that harm reduction was developed in response to stigma. It's a way to mitigate stigma. So, you know, I'm often struck by the fact that I am frequently sort of myself in a way shaming people, like in my head, I'm shaming people that don't embrace harm reduction. And I need to call myself out on that, right? So like I need to flip my own script and think about ways that we have to harm reduction, you know, practice harm reduction with those who aren't on the same page with us in terms of, you know, how to approach public health. So, yeah, I don't know. I think that anytime we're, again, reinforcing that binary perspective, that approach, we're shutting down opportunities for learning and for conversation.
How about when folks are so far the other direction that COVID is a hoax, that it's not real, it's not serious? How does harm reduction play into that? Because it's hard to imagine letting people just, oh yeah, it's a hoax, that's okay, you can think that.
Oh, I don't, yeah, I have a lot of thoughts on that. Sorry, Mary, do you mind if I jump in?
Please do, yeah.
Yeah, I mean, I think this is actually where harm reduction can be so crucial. So it's not about saying we're gonna let these people do their thing. And I think that's sometimes a misconception about harm reduction is, it's almost like, you know, people will push back on some of the stuff I say, and they'll say, are you just saying we should tolerate people partying in a pandemic? And it's like, no, that's actually not at all what I'm saying. I'm saying let's try to figure out how we can help people be safer in a pandemic. And for people who believe COVID is a hoax, and let's say are, you know, proselytizing about not wearing masks and how it's all a conspiracy, that's where compassionate messaging is essential. So when we dismiss people and we say, these are stupid theories you have and you're just wrong, we will make no progress. And I'll just give a little anecdote about this. I wrote a piece about masks for The Atlantic a few months ago, and I framed it around somebody who was a very vocal anti-masker, and somebody who proudly supports toxic masculinity, somebody who's very, very hard to empathize with. But I argued that we cannot dismiss even people like him, like that public health is actually about serving everyone, and he is putting other people at risk. And so we have to try to get him and people like him to wear a mask, even if it's an uphill battle. And the way to do that is to humanize people and to really think about what is going on for them. And after I wrote that piece, I had all these guys contact me because it was called The Dudes Who Won't Wear Masks, and all these men contacted me and said, thank you for being compassionate and being a public health person who's not condemning me. And I actually had conversations with them, and some of them changed their minds. And it doesn't take much. I mean, yes, a one-on-one conversation is not scalable, but that kind of messaging, I think, can go a long way to reducing some of that polarization and some of the ways that people can be driven away from public health when it's much more paternalistic and absolutist. I think people are drawn in a little bit more when there's more nuance and more recognition of people's humanity.
Yeah, that's great. You know, the one-on-one conversation is not scalable, but if we all are having those conversations, that becomes more scalable. And so this conversation also makes me think, Julie, about that early slide you had pointing out that like the abstinence only approach versus the harm reduction approach, how they're binary. And I think we also know that it's the abstinence only that becomes binary with harm reduction. It's not abstinence. Right? So abstinence actually has a place on the harm reduction continuum. There are great harm reductionists, people that fully embrace harm reduction, that are in abstinence-based recovery. So they used to use drugs, they don't use any drugs now. So there is a space on the continuum for abstinence-based approaches. And so, you know, I think, again, it just underscores the point that the idea is to, you know, strive to understand where decisions are being developed and where people are getting their information and how they're deciding how to mitigate COVID risk. And again, moving away from that binary perspective.
It's pretty complicated, allowing all this kind of stuff to exist in the same space, right? And I really appreciate it, like you brought up, Dr. Marcus, the New York Public Health glory hole thing. I thought that, you know, whenever you convert glory hole into a public health campaign, it's got merit. But how do you send a message to folks generally that can be this complicated? I mean, you know, wear a mask with an asterisk, and then if you want to, if you can, if you like, how do you do a complex message broadly that incorporates harm reduction?
Yeah, I think sometimes there's a resistance to harm reduction because it necessarily involves more nuance and complexity, and it's easier to just say hashtag wear a damn mask. But actually, I think that kind of absolutism is part of what pushes people away. And when we say it's important to wear a mask, we understand nobody really wants to, but it's important to wear a mask, especially when you're close to people and especially when you're indoors. That's a more nuanced message that didn't take me very long to say, but it's much more nuanced than saying wear a mask at all times when you're out of your house. You know, there's a little bit of empathy, there's a recognition nobody wants to do it, there's a recognition that there's a spectrum of risk, that wearing a mask when you're walking alone outdoors is, you know, not going to do anybody any good. And when we don't have that kind of nuance, we end up with policies like the ones we're seeing popping up now, where people are being policed for not wearing a mask outdoors when they're walking alone, which is just a totally misguided public health policy, in my opinion.
So is in Notre Dame turn your fellow students in for not doing things right,
right. I mean, the amount of policing that's going on, not just by police, but also, you know, we're finding ways to make people police each other, is, I think, going to be counterproductive in the long term. But yeah, I think it is. Yes, it may take more words and it may take more thought, but I think people can handle nuance, and we have to treat the public like they're adults and like they can handle it, because they can, and they actually can see right through it when we're absolutist and we're getting away from the actual science.
I would just add to that by saying that whenever we are taking that approach where we're sort of ratting each other out and policing each other or policing people, it's always going to exacerbate inequities. So I'm quite confident that privileged people, which in our country largely means white people, are going to be policed. I even hate to use that term when we're talking about racial oppression, but will be monitored in that way for their COVID behavior or lack of risk mitigation much more leniently than people who are oppressed.
Does harm reduction have limitations? If so, how do you address them?
Everything has limitations, right?
Yeah, I'm just
Great question.
trying to think about what specific limitations we've thought about, like how to capture that.
I mean, I'll say one limitation, and maybe this is not, so one is the one we just talked about, that you can't just have a stay home message. Like you have to, it requires a lot more thinking, more words, maybe more space on a guidance page, whatever. Like it just is harder. It's harder, but it will be more effective, but still takes more effort and thought, I think. But also there's a lot, this is maybe not a limitation of harm reduction, but a limitation of our societal approach to it, but there's a lot of resistance to harm reduction. And that can make it kind of an uphill battle to push this kind of framework, because people will say you're promoting risk taking, you know, you're minimizing COVID, you know, in this case, like I get all sorts of fun hate mail. I mean, good mail too, but I think there is historically in the US in particular a resistance to harm reduction for substance use, harm reduction for sex, and now harm reduction for COVID. And I think that can make it almost a limitation just in that sense, that it's just challenging.
Yeah, and I think one of the reasons for that is that, particularly when we consider a medical model, we know that when there is empirical evidence that a certain health behavior is going to produce better health outcomes, that's what we want to stick with, right? So I think for providers, it can be really hard to apply harm reduction principles because they have empirical evidence that if you just don't use drugs, you'll have better health outcomes. But when we fail to understand, as you were saying, Julia, the context about why people are using drugs, we're failing to engage them, we're failing to serve them. We risk, you know, completely alienating them and having much worse health outcomes. And so we often think about ways that we can consider harm reduction, the application of harm reduction, you know, and recognizing that limitation, if you will, by extracting it, by applying it to other health issues. So the classic examples we use are that, you know, if you have diabetes, we're really happy you didn't eat the whole cake and you only had a piece of cake, right? Yes, no cake would be ideal, but a piece of cake is better than the whole cake. And so we're able to see the way that makes sense when we apply it to diabetes, much less so than when we're talking about people with substance use disorders or people who use illicit drugs, unfortunately. So I think, you know, part of our challenge is getting people to think about it in ways that is sort of safe for them, thinking about, you know, eating too much sugar, and getting them to, you know, apply those same thought processes to things that they tend to maybe feel a little bit more, you know, black and white about or moralistic about. And another great application, I think, of harm reduction is that's often intuitive for people is when we think about people who experience intimate partner violence, we can understand the value of encouraging them to have an exit plan, or, you know, having ongoing conversations with them about when they're ready to leave a relationship or be as safe as possible in that relationship without necessarily having to leave that relationship completely. But it's, you know, that might make sense to us, but it's rare that we're able to use that same thought process when we're thinking about health behaviors like substance use or not wearing masks that are just harder for us to wrap our heads around because we are, I mean, some of it is being moralistic and some of it's being stricken by fear, but neither of those are reasons to stop conversations about, you know, moving people along the harm reduction continuum.
So we have at least one question about looking hopefully into the future to when there's a vaccine. Is there a role in vaccine distribution, vaccine information messages, whatever, and harm reduction?
You know, a huge component about harm reduction that we didn't talk about is that all of this is really very much related to health literacy. So sharing information with people that's most useful to them, is, a big part of what we do with building people's health literacy. And that's what the first thing that came to mind for me, Jamie, when you mentioned that is, improving people's health, strengthening people's health literacy, because, we're definitely seeing that there are people who are saying, if there's a vaccine, I'm never going to take it. It'll be, I just don't trust that. So harm reduction offers us the opportunity to build people's health literacy and also kind of start where they are and understanding what their resistance is and helping them, roll past that ambivalence and accept the possibility of a vaccine should our public health evidence show us that that's the move.
Yeah, I'll just second that I think the principle of meeting people where they are is going to very much apply to the vaccine and vaccine hesitancy. And there's a lot of research on vaccine hesitancy from other settings that I think has also found that when you really try to figure out what is going on for people, you end up being much more effective in your messaging instead of just saying, why would you do this? You need to do this. And even mandating it, I think instead really trying to build that trust through building health literacy and then also understanding what people's barriers are so you can try to help overcome them.
So let's take that theoretical into a practical. One person is going to volunteer at the polls for our election coming up. Don't forget to vote. And they've been given instruction that they'll have masks probably to hand out to people who aren't already wearing masks. And they are asking about how to best approach people to ask them to wear a mask.
Yeah, I mean, I think I really believe that it can, in addition to just kind of kindness, we're asking people to wear a mask just while they're here. Making the ask as small as possible can help as well. So I think some of the resistance to masks and in general to public health efforts right now is pushback on absolutism. So the more that we say, like, I need you to wear a mask at all times, the more people will say, that's stupid, I'm not going to do that. But if we say, we're expecting, we just like people to wear a mask for the 5 minutes that they're here voting, and you can just throw it away on your way out the door, then it becomes a very small ask. And even somebody who's resistant to wearing a mask in general might say, okay, fine, 5 minutes, I can do that, So I think those two things, kind of taking a friendly, kind approach and also making the ask small could help. But that's actually not, that's just me like opining. That's not me coming from any research-based perspective.
I would second that. I would also say anecdotally, I've experimented with this a bit in my own life. Earlier, this summer, I had this moment of, I don't know, I just was stuck in a place where I just felt really angry about where we are. I'm still kind of angry about where we are. So I still need to harm reduction myself a bit, but I have asked people to wear masks when I've seen them in public in an angry way, like a scared way. And I've asked people to wear masks in public by just like, trying to connect with them in a kind way and actually just like giving them a mask saying, oh, I have an extra one, would you like it? And the second way has gone much better, not surprisingly. So I think there's value in what you're talking about.
There's a third way too, to just stare at them and passively aggressively, just like stare them down. Is
that working for you?
No, it's not. We're down to like 5 minutes left. So I just wanted to give you both an opportunity to say anything you want to say in terms of wrapping up around whatever in harm reduction.
I mean, I will just say that the root of all of this really is compassion and being humanistic, whether we're talking about the pandemic or we're talking about substance use, because anytime that we fail to dignify people and respect them, we do risk losing them and we're not serving them well as public health professionals, as medical professionals. And I will also say that, we just received notice like an hour ago that our campus is moving toward a guarded position within the next 2 weeks, which is great, right? That's an indication of it's a suggestion that some of the public health efforts are working. And I think it's going to be really important that we don't, I said that we should prepare for backwards movement and that happens, if it happens, we shouldn't become hysterical and frustrated and scared, but rather think about how to be, continuing to engage in conversations with people about how to return to the safest possible behavior should that happen. And I would also say that if we do move to guarded, it will be important that we don't sort of peer pressure people into engaging in things that they're not yet ready to do. So we may have more in-person classes, but everyone might not be ready for that. So it's going to be, again, important to consider where all of our students, all of our community members are. And Julia?
Yeah, I think I really appreciate your message of compassion and humanity, because I think there are ways that, I write and talk a lot about public health messaging, but I think there are bigger ways that we have lost a little bit of our humanity during this pandemic. And I think on an individual level, we can see it happening and feel it happening when we, let's say, see people out in public or in the store, and our first thought is not, there's a human being who lives in my neighborhood and is out getting groceries or is having a lovely picnic in the park. Our first thought is, are they wearing a mask? How far apart are they from other people? Are they really in the same household? And so we've reduced people.
Just last week.
What's that?
They went grocery shopping just last week.
Right, and then we go to judgment, and we've reduced people to vectors of disease, and we have to remember that people first and foremost are human beings, and not just in our public health messaging, but this is like an impassioned call to just bring back our sense of humanity in all of this, because whenever we see people as human beings first and foremost, then we can remember what their needs are, and we often have shared needs. And yes, people make different choices from us, and we have different levels of risk tolerance. And yes, the choices that other people make in a pandemic do have impacts that go beyond themselves. Like, it's not just harms to them, it's potential harms to other people. So our frustration and our judgment is understandable, but if we can humanize people, I think we will get so much further in this, and with resilience and with our, preserving our collective humanity.
Fantastic. That was crazy interesting. Thank you so much for both of you for taking the time to talk to us today. We're out of time, just perfectly, which is good. I just want to make a couple quick suggestions. Dr. Hawk has a harm reduction class that she teaches. So for Pitt students, you may want to check that out in the fall again. No.
So it's actually a half semester seminar. So it starts in 2 weeks.
Oh.
Matter of fact.
We'll have time.
But only 3 seats left, so.
So that might be something you want to check out. And also, just to remind you that the website is at Pitt Public Health, and you can review previous ones, and you can go back and listen to this one again because it was so great. And you can tell your friends too. And then next week again, it's going to be Dr. Friedman and Dr. Freer talking about HIV in the age of COVID. So thank you all very much for coming. Really appreciate it. Have a great weekend. Enjoy the weather while we have it.
Thank you guys. Take care.